Good afternoon, everyone who's both here and in person. We are delighted to introduce you to today's speaker, who many of you already know, Archit Pothasaru, who was the inaugural IHDD Fellow and spent 11 months working here at the Institute for Healthcare Delivery Design. This fellowship was something that he had a very strong hand in designing and actually came to us with the idea to do it, and embraced and dove into a domain which he had just a glancing familiarity with, and over the course of a year was able to not only integrate what he was learning here through projects and through education, but then cross-fertilize this with his experience as a doctor in training, and has come up with some very insightful thoughts about how to really bring these two fields together. And we've benefited enormously. So without further ado, Archit, take it away.
All right. Thank you, everyone, for coming here today. I'm Archit Pothasaru. I'm a fourth-year medical student here at UIC, and I just finished 11 months, just as Hugh said, training at the Institute for Healthcare Delivery Design. So Hugh mentioned that I had some thoughts about the field of design and the field of healthcare in general. That's too hard for me to tackle today. So specifically, what I wanted to talk about was bridging design thinking or human-centered design in medical education. So basically, if you take someone who's training in medicine, whether they're a nurse or a physician or any sort of healthcare practitioner, and you sprinkle a little bit of design on them, what happens? Like, is there a point? And Dr. Krishnan was worried that I had too many slides, but I only need one slide. Basically, not only is it beneficial, it's possible. The second part is important because if it's beneficial, but it's not possible, it's not plausible, there's just no point taking the time to think about it. What I'm going to be trying to argue today is that this dual training, it's not necessarily for everyone. It doesn't need to be mandated, but there's some very clear benefits that come when you bring these two fields together and train someone in a little bit of both of them. And also that you can do it again. So just because I did it doesn't mean no one else can ever do it again. It would kind of suck if no one else ever did it again. I did want to spend a very brief amount of time talking about human-centered design in healthcare. Kim Irwin is smiling because I stole this slide straight out of her deck. And what differentiates design from science is that it centers specifically on people, their context, and their behaviors. So what I mean by that is in science, we're often trying to look for this grand truth. So if you cut open a body, not to be too morbid, you'll see a heart, you'll see two lungs. If the person doesn't breathe too quickly, their pH will go down in their blood. If they breathe too quickly, then their pH will go up. These things are facts. They happen in every place at every time, in every country, in every state, and in every city. The key insight of design, and this is really what popped up in the second industrial revolution, where mass production had a bunch of products that were the exact same for everyone. Design grew as a field because they recognized that people have individual specific needs and individual specific perspectives that you can design for. So when we're talking about problem solving that centers on people, so what do people specifically need? Their context, so how does where they live affect how they interact with the world and their behaviors? So not just what they say and what they think, but actually what they do and what they feel. Design can help you give a little bit of insight into giving people what they want. And this isn't anything new. This is huge in the fields of business. It's taught in every single top business school in the US. It's just not really there in healthcare yet. And when I was an undergrad at Vanderbilt and I would head over to the medical school to sit in their lectures, every single lecture, whether they were an artificial intelligence expert, a cardiologist, a public health expert, it always started with the same two slides. And so I wanted to start my presentation with the same two slides as well. The first one is that the US is a world outlier when it comes to healthcare spending. We're the very black line at the top. We spend 18% of our national gross domestic product on healthcare, but we don't get the outcomes that we expect to be paying for. We have the lowest life expectancy of developed countries. We have more avoidable deaths, meaning deaths that are amenable to healthcare. And if you're thinking that these are population health statistics and not reflective of what's going on in the hospital, that's not true. We have the highest levels of infant and maternal mortality in the world, just period. And these outcomes are also deeply inequitable. So if you go state by state and you look at the health outcomes that Black Americans, American Indians, Alaska Natives, and the Latinx population have, it's not comparable to their white fellow citizens. So not only are we not having great outcomes, we're having deeply inequitable outcomes. And specifically here in Chicago, if you look at the difference in life expectancy on the south side versus the north side, it can be as large as 17 years. That's 17 years of life lost. And you can make the argument that 80% of what happens for a person's health is the social determinants of health. It's outside of the clinical setting and therefore outside of the purview of physicians or physicians in training. This is the Office of Population Health Sciences. These are inequities that we're here to basically try to work on. Importantly, healthcare is also only going to get more complicated. So we already are dealing with a complex system where there doesn't seem to be a good one-to-one ratio between the money that you put in and the outcomes that you get out. And it's only going to get more things are going to end up happening. So first off, I talked a little bit about the social determinants of health. We're increasingly using the social determinants of health to change our treatment algorithms. Healthcare is going to get a little more complicated as we try to do that. We also saw with the COVID pandemic how new modes of delivery and technology affect the way that we do things. If you go into a restaurant now, they won't hand you a menu, they'll just put a QR code. Every industry has adapted to the changing market, to the internet. You have direct-to-consumer models like Amazon. Healthcare is starting to do that. We're starting to see that, for example, with telehealth. And it raises questions about, again, how should your treatment algorithms be different when, for example, you're doing remote patient monitoring and trying to get someone out of the hospital faster. And then finally, reimbursement models are also going to change. So for a long time in the US, we've had a fee-for-service-based reimbursement model, and we're increasingly trying to reimburse based on value of services delivered rather than volume of services delivered. It sounds like something that could be an unequivocal good, but it also adds some complexities. So take, for example, you don't want a patient to be inappropriately readmitted. So if I have heart failure and I've gone to the hospital and maybe someone messed up my discharge paperwork, I don't take my meds properly, and I get readmitted, it seems reasonable to penalize hospitals for high levels of 30-day readmission. But conversely, you can have increased mortality. You can have patients who need to be back in the hospital who aren't going to be able to get back in the hospital. So I don't bring all of this up to say that healthcare is good or healthcare is bad. It's just that medical students, when they're coming into medical school, they have this pressing need that they need tools to navigate uncertainty and solve difficult problems. And it's more than just what can we do in the clinic and how do we treat people. So when I was a first-year medical student, I dug out this email all the way back from 2019, where I said, I emailed a guy named Dr. Jerry Krishnan, who I found on the internet, who did something called population health science and something called healthcare delivery science. I said, hi, I'm Archit. I don't know anything at all about healthcare delivery science. All of my research was on basic sciences. If you want me to image a cell, I can image a cell for you. If you want me to do anything else, find someone else. Can you help me out, basically? And what Dr. Krishnan did was he introduced me to my other mentor, Hugh Musick, and they put me in this place called the Institute for Healthcare Delivery Design in between my first and second year of medical school, and that summer in between. And what I really want to highlight here is first, human-centered design methods. So IHDD is essentially an academic consultancy that works with healthcare organizations, government agencies, researchers, and they're trying to use this human-centered design methodology that's not native to academic medicine, but trying to bring it in to see how can we potentially do things differently, both within the four walls of the clinic and outside of the four walls of the clinic. And so this is the question that I'm going to be trying to answer today. How might dedicated training and healthcare delivery design help with this problem that today's medical students need these tools to navigate uncertainty and solve interdisciplinary problems? And so when I'm going to attempt to answer this question, I'm going to be going based off of my own training here at IHDD. So my summer internship between my first and second year, and then the one-year fellowship that I did in between my third and fourth years of medical school. And I'm also going to be going off of some of the things that we found when we went outside of UIC and talked to a bunch of different other institutions. MCW, unfortunately, Medical College of Wisconsin is cut out. But we talked to a bunch of different institutions who were in some way, shape, or form trying to do something with design thinking and human-centered design in their core curriculum for medical students. So I took a year off from medical school to train in design at these places. UIC is actually one of them. I'm just not in the program for teaching design. At these other places, they're actually just teaching medical students. And so we surveyed educators from these different institutions. We conducted interviews with them, did some thematic analysis, and we tried to figure out, okay, like what's the point of this? Like if I'm a medical student, or if I'm an educator, or if I'm a designer, why should I care about dual training at the intersection of human-centered design and medical education? And again, this is my first slide, but I'll reiterate again. Dual training is not only beneficial, it's possible and it's repeatable. So let's start off with that term beneficial. So the very first thing that we saw, and this is what we commonly talk about in design, well, not we about design, but this is what designers commonly talk about when they say what is like a core benefit of design. And it's this idea of problem definition skills. So medical students are fantastic problem solvers. We're professional test takers. We go into the clinic and into the hospital setting, and we deal with these complicated patients and try to figure out what's going on. But often we don't know what exactly is the problem that we're trying to solve. And Santosh Basapur, who actually caught that I was showing my notes to everyone instead of my slides, had a fantastic quote about this. He says that medical students are fantastic ideators, just that they ideate without context. So if you ask them, what should you do about X? They'll say, you should do this, you should do that, you should do the next thing. And then if you ask them, so who should you talk to actually try to do that, they'll give you a blank stare. Or if they give you an answer and they say, you know, talk to an insurance company, and you ask them, you have 30 minutes with the CEO of Aetna, what do you do? Again, it's not, they're fantastic if you give them the context, but they don't yet know that you need to have context in order to solve a problem. And so by developing problem definition skills, you can comprehensively both define and also redefine problems before you jump all the way forward to solution generating phases of a project. So that's the first benefit, key benefit to medical students when you train them in design. The second thing is that they get better at collaborative practices. You know, in design, we often talk about this first benefit, but I actually think the second benefit is a lot cooler and a lot better. What happens is, so inherent in the process of design, you're trying to engage with different stakeholders and talk to people about what they're trying to do. And sometimes, not all the time, but in research, we may think about stakeholder engagement as something that's the morally right thing to do, to talk to the stakeholders, get them involved, but it's burdensome because you have to talk to like 30 people, 50 people, 70 people. The core insight of design is not that you do stakeholder engagement because it's a moral right, but you do it because your solution will fail if you don't engage your stakeholders up front. Absolutely. You have to go and talk to everyone straight up off the bat. Medical students also get better at interdisciplinary thinking, so they get a sense of how people will think in different fields. So how might a business person think about this? How might someone from insurance think about this? I'm a physician and I think a patient should be treated this way. How does the nurse who's actually taking care of the patient and sitting there by their bedside all the time, how do they think differently? And not just interdisciplinary thinking, but also interdisciplinary collaboration. So not only do you start to think like practitioners from different disciplines, but you actually know how to find them and talk to them and ask them questions and not waste their time, and get in a Zoom meeting where at the end of the Zoom meeting, they don't feel, man, I never want to get on a Zoom call with this guy ever again. So those are the two key benefits that we're going to go over. And I have a brief case study for each of these. I didn't want to go into granular detail about every individual thing I did in the fellowship, but I wanted to paint some broad brushstrokes. So we'll get a little bit deeper into these two later. Basically, it boils down, ask the right questions, find the right people. And the other two themes are really what the key principles are for designing these training programs. So if you're interested in learning about human-centered design or incorporating design, and you have a clinical career, a lot of the times I'll be talking about medical students and clinical careers because that's my bias, but really anyone can train in this stuff. So forgive me for that. But it's the two principles. You have to balance interest in design with the competing requirements of medical school. So if you want to get a medical student to train in design, you got to dangle something in front of them that they can show to residency programs when they apply to residency programs at the end of the 4 years. Otherwise, they're not going to be particularly interested. The first time a stiff wind comes, it's going to blow them over. So making sure that there's dedicated time to focus on healthcare delivery design, but also making sure that students are getting outputs. And honestly, even young professionals who are interested in design, making sure that they're getting outputs that are relevant to their field, not just relevant to design. And secondly, making sure that the program is suiting any local strengths and needs. So, I mean, I didn't do anything with product design in the last 11 months. That's just because we don't do product design at IHDD. That's not a flaw. I'm not trying to say that every design program should be focused on product design or focused on service design, But if you're interested in getting some experience, just see who are the designers around you. Design isn't one massive thing where everyone is a visual designer, everyone's a graphic designer, everyone's a fashion designer. Find out what the local expertise is and weave in the program to use that local expertise instead of just trying to have this standard program and do the exact same form of training at every single different institution across the country. And again, these programs are not just, it can be for anyone in healthcare, not just medical students. That's what the blue text says there. Absolutely anyone can do this training. So these are our 4 major themes. We're developing problem definition skills. We're building interdisciplinary ways of working. We also need to make sure that we balance the requirements of a career in medicine with training and design, and that we're tailoring programs to local strengths. So we're going to go through these one by one. And I'm just going to give a brief case study for these about, some of the things that I did and what my personal experience was when I was doing projects at IHDD. So we're going to start with problem definition skills. I'm going to start with, there are a lot of different frameworks in design. There's no one right way to do it. But this is the most common one. It's something called the double diamond. Basically, the idea is that there are 2 overall phases to any project. The first thing is you want to make sure that you get to the right problem definition. You get to a defined problem and a plan of attack, and then you get to a solution. So you start out by diverging, going as broad as possible to come up with as many different ideas of what could be potentially going on, what your questions are, and then you converge and narrow down into a specific question. Once you have your specific question, again, you diverge, go really broad into all of the different solutions that you could potentially come up with, and then you converge into a specific set of solutions. So I was exposed to this just a little bit when I was a senior and studying biomedical engineering, and my hypothesis coming into this fellowship was that if you took a medical student, they will be fantastic at the converging sides of this double diamond. So they'll be good at phases 2 and they'll be good at phases 4. If you give them a whole bunch of ideas, they'll be able to narrow down. We take too many multiple choice exams. I was going to say a different word other than too many. We take too many multiple choice exams. We're really good at multiple choice exams. We're good at narrowing down. We're good problem solvers. So this is my theory, that we would be good at converging and not that good at diving. So the very first project that I did well, not the very first, but the first project I did in my fellowship was part of our human-centered design certificate program. And we worked with Paul Chan in the Department of Ophthalmology. And our mandate basically was to look at this machine called the iNook, which is an artificial intelligence diagnostic solution for diabetic retinopathy. So patients with diabetes have chronically high levels of sugar in their blood. And blood is like the plumbing system for your entire body. And sugar, having a high level of sugar is kind of like setting that plumbing on fire. So over time, one of the things that can happen is that the blood vessels in your eyes for patients with uncontrolled diabetes can start to fray a little bit and they can have some difficulty seeing. The good thing is that if you catch this really early, the treatment is very nice, it's very simple, and you can save someone from losing their vision. And so the nice thing about the iNook is that because this is artificial intelligence, any physician can prescribe this. You don't have to be in the Department of Ophthalmology and ophthalmology clinic visit. And imaging itself can be done by an operator with a high school diploma. So we talk about physicians practicing at the top of their license. You could have someone else in the clinic actually do the imaging itself, identify if a patient is at risk for diabetic retinopathy, and then and only then send them off to the ophthalmology clinic to actually get like a full dilated eye exam. So this thing is fantastic. It seems like a slam dunk. All you have to do is just plop it into the Department of Family Medicine, plop it into the clinic where people are getting their PCP appointments and get them screened, and all of your problems will be solved. It's not that simple. So what we first did is this is what I'm talking about with interdisciplinary collaborations. We spoke to administrators, staff members, and physicians, both on the Department of Ophthalmology side, which is highlighted in pink, and the Family Medicine side, which is highlighted in blue. Don't worry about being able to read the individual text. The reason why I put the diagram is just to try to visually represent how many different people that you may potentially need to talk to. So we're speaking to stakeholders both in the family medicine clinic and the ophthalmology clinic. And what we found is that this isn't a screening tool, it's a triage tool. And what do I mean by that? The referral rate, the completed referral rate for people who are in the Department of Family Medicine, who get a referral to see their ophthalmologist for a dilated eye exam. Guess what the completed referral rate is? What % of patients actually complete that eye exam? Yeah. You knew I was going to give a low number. It's 11. So you cut my thunder, but 11 is still a small number. 11 is still a small number. So only 11% of patients. So think about that. You would have to screen like 10 patients with the INUC in the clinic to get one of them to actually get a dilated eye exam that they wouldn't have had otherwise, right? That's a huge number needed to treat. Also, so that's the second point, that the referral is just as important as the screening. Also, the point of the screening is not to determine who gets an eye exam and who doesn't. This is a screening tool that just looks for diabetic retinopathy. There are all sorts of other eye diseases that you can have, and people still need to have an annual eye exam. So when we were going in our problem definition exploratory phase of investigation, one of the things that we realized was we need to make sure that people recognize that this screening isn't a substitute for a comprehensive eye exam. The point of this, and I'm just going to move the video over to this side, the point is that it'll actually triage you and determine how quickly you need to be seen. And so we don't want to implement a solution where people are getting screened, and let's say it comes back as negative, and they say, great, I don't need an eye exam this year. And then they get glaucoma, which isn't picked up, which is not diabetic retinopathy. So we found out that it's a triage tool and that the referral is just as important as the screening. These are things that, what I've found a lot when I talk about design is that in hindsight, when we explain what our big finding was, it comes across as very obvious, and it comes across as something you should have known from the very beginning. I prefaced it at the beginning by saying that we could just plop the machine in family medicine and call it a day, to show you that it's not that simple when you don't have the benefit of hindsight. It's important to have these exploratory phases at the very beginning of a project in order to define the problem. And so what we did is we defined the problem as, how do we leverage INUC to increase the rate of completed referrals from family medicine to ophthalmology. So I'm not going to go into details into what our final solutions ended up being, but in general, it just ended up focusing a lot more on what the checkout process was going to look like, what the patient education process was going to look like. Even though we were using this tool and we had spent a lot of money on this machine, the point is to get patients to see their eye doctor, not to get patients screened by the machine. And then again, I'm just going to reiterate this quote because I think it's just such a fantastic quote. A designer is trained to investigate and then ideate. Medical students are trained to just start ideating solutions as soon as you see a problem. So let's say, for example, that I'm in a school lecture and someone says, a 60-year-old male comes into your emergency department with shortness of breath. Immediately, I have to start coming up with ideas of what may be going on with them, what's happening, what's my treatment algorithm, what do I want to get started for them, what questions do I want to ask. The idea is that we want to take that ideate without context and convert that to ideate with context. So I'm going to come back to this double diamond. How does that affect my hypothesis? My hypothesis was that medical students are good at converging. They're not as good at diverging. I was wrong. If you look at this quote, Santosh is saying that medical students are actually really great at converging. It's just that they start at phase 3. So they're starting by just generating ideas, but it's not even like they can only do the back half of each diamond. They don't even know that the first diamond exists. They go straight to generating solutions. They're very good at generating solutions. You can get fantastically creative solutions if you just talk to M1s and M2s about how they'll change healthcare. It's just that, you need to be in the real world and for projects a couple of times to recognize that the exploratory phase matters. So we talked about problem definition. Let's talk about interdisciplinary ways of working. So for this case study, I'm going to be talking about something called the hypertension action plan. So essentially what happens, and I'm sorry, it looks like the colors aren't coming up too well, but it's okay. The slide doesn't matter as much as the content does. Essentially, Blue Cross Blue Shield came to UIC and said that we want to do some work towards improving health equity. And so this is a project that's underneath the Health Equity Pilot Program. And they gave UIC, I think, over $6 million to look at how we can improve health equity, because we are, well, sounds like I was off, it's a lot more. But basically, what can we do? So one of those specific problems is we have a lot of patients who don't have access to great health insurance, who don't have access to safe neighborhoods, who have really, really chronically elevated blood pressure. And blood pressure is the thing that you always hear physicians get memed on about, because they'll always say, lower your blood pressure, but no one knows, you can't feel a blood pressure of 150, but it's one of those things it's a silent killer. You'll get problems down the line 20, 30 years later. And so our goal here is basically, how can we reimagine how we take care of hypertensive patients? So by the time that I had come onto the project, they had already come up with this fantastic booklet that you can sit down with a patient, take 30 to 45 minutes, explain to them exactly what hypertension is, What are the different problems that can happen if you don't control it? Here are some 6 different, very easy places where you can set goals. It was a great booklet. The only question is like where do we put it? It takes 30 to 45 minutes to do. A PCP visit is 20 minutes. So we came up originally, this was our initial problem statement, a hypertension specialty clinic. So in the same way that you can go to a specialist, like a GI specialist or a hematology oncology doctor, can you go to an integrated hypertension specialty clinic where your PCP just writes a referral, you go off to the specialty clinic, and you'll have a pharmacist, a nurse practitioner, a peer navigator, a social worker, a nutritionist, all of these different resources basically to help you with your blood pressure journey. We pretty quickly figured out that that's not going to be possible. It costs way too much money. You don't have a clear financial endpoint. It's not something like, for example, bariatric surgery, where you will get these wonderful integrated education-focused clinics because they have a clear endpoint of the financial surgery where they can get revenue. And blood pressure doesn't work like that. It's really hard to set up a specialty clinic. And so instead, we tried to figure out, okay, what's the most important part of this massive bubble? And we decided that it's the peer navigator. So we looked for existing patient engagement mechanisms that are at UI Health. So before we even wanted to create a new peer navigator, so in this case, a peer navigator is someone that you can talk to. They have the time to spend 30 to 45 minutes to you to talk about blood pressure and learn about your specific goals. So we wanted to see, do they already exist? And they're like 4 different names for the same thing. And they all exist and they're all doing different things and they're all in different places in the hospital. There are community health workers, there are patient navigators, care coordinators, health promoters. And so we wanted to figure out, okay, we have all of this existing latent energy within the healthcare system. How do we actually get it to converge together? So again, don't worry about the words, just worry about like the visual of the visual. So there are all of these different individual systems that are not working in a coordinated way within UI Health. What we did was try to find a way to integrate them all into one streamlined process. So we have 3 existing care coordination services at UI Health. How can we figure out who actually staffs the patient navigator? Where do they sit? How do people talk to them? Where do they get referred to? So we can build this seamless experience where after your clinic visit, let's say you've just been diagnosed with high blood pressure, or you've had high blood pressure and you and your primary care provider have had difficulty getting under control. We can do 10 minutes of education, 15 minutes of action planning, a quick demo of how you learn how to do your blood pressure cuff. And for 6 to 8 weeks afterwards, someone actually calls you personalized to what specific goals you set and asks, hey, did you focus on feeling a little bit less stressed this week? Or hey, how did you feel that you did with your diet? This is like, it seems really simple. If you just ask someone to come up with something, you wouldn't pay like $100,000 million for this. You would feel like you got scammed. But the important thing is that it's hard to actually get this stuff to work in the real world. We had to coordinate between a social worker, a primary care physician, the principal investigator, the person who would get approval from the institutional review board, different experts who have different opinions of how we should do it, a project management expert to make sure that we all stayed on track. And that's what I'm talking about when I'm talking about interdisciplinary ways of working. It's not just about the solution, it's about coordinating people to get the solution to live in the real world and have real world impact. And we saw some good results. This is a very preliminary pilot data with about 26 patients over about 6 to 8 weeks. We saw a reduction in systolic blood pressure compared to patients who didn't go through the hypertension action planning program of 10 millimeters of mercury, which is a pretty big deal. And the confidence interval, 95%, shows that it's statistically significant. It's not something that we just saw by chance. I'm running out of time, so I'm just going to go through these 2 at the same time. We talked a little bit about some of the benefits, problem definition skills, and interdisciplinary ways of working. Now, what do I actually tangibly mean when I talk about making these programs work? How can you balance the requirements of a career in medicine with dedicated training and design? And how can you tailor programs to local strengths? So I spent about 1.5 years in total at IHDD. So the summer between my 1st and 2nd year of medical school, and then the full year between my 3rd and my 4th year of medical school. So when I was meeting with Hugh and Dr. Krishnan monthly during my 3rd year, just to try to figure out all the nuts and bolts of what the heck I was going to do for 11 months where they had me, we tried to come up with these 3 different prongs of attack. So first, theory. Can I develop some dual expertise in human-centered design and implementation science? Implementation science is the language that they use in academic medicine. And so if I'm going to be trained in human-centered design, I also need to be able to speak the language of fellow physicians, fellow physician scientists, who are using the terms of implementation science and may be naive to terms like human-centered design. So that's one example of balancing the requirements between a career in medicine and between training in human-centered design. We also made sure that I got practical experience on IHDD projects, and then also that there is this ongoing dissemination, tangible outputs that I could point to, like abstracts for conferences, peer-reviewed publications, something that I could, when I turn into a pumpkin at the end of the night and I become a medical student again, I can show that I was up to something relevant to my medical career. And at the very bottom in green, you'll see something called a capstone project. So this is the survey that I talked about earlier, where we talk to different people who are looking at design thinking education programs within medical schools. And if we put that capstone project way at the beginning, I would have done a horrible job because I wouldn't have known how to interview people. I wouldn't have known how to talk to people. I wouldn't have known what the point of what I was doing was. I would have gone all over the place. So it's important to be grounded first in things that are relevant to your experience in your clinical career, and also get some tangible experience in the way designers do things before you get into the way that you want to do things. And then only then, when you've gotten trained in the nitty-gritty details of executing a design project, can you try to do things on your own. I also just wanted to highlight, so we talked to a total of 7 different institutions. Look at how much variability there is in estimated contact hours. There's some programs where over 4 years, they spend only 12 years with students. And there's some programs where over 4 years, they spend 180 students. Again, don't focus on the details of the table, but just focus on how large the discrepancy is. I highlight this not to say that anyone is doing this right or wrong. They're just doing it in the ways that are uniquely suited to their environments. So in some places, like the University of Virginia, Matthew Trowbridge is a fantastic educator. He has experience in design. He can really only dedicate 10 hours a semester to the students. He's running the program basically all by himself. Somewhere at Vanderbilt, where they have the Medical Innovators Development Program, where they have a whole suite of academic faculty focused on this in a robust recruitment system, they can spend 180 hours plus with students and connect them with industry internships. The important thing is that you make sure that it's tailored to the specific locality. Again, I don't want to say this in the sense that, design is some intuitive thing. You can just sprinkle a little bit and learn it all. You don't become a designer at the end of this. Design is hard. Design is rigorous. There are a lot of different ways that you can mess a project up. The point is that how can you just train someone a little bit in design, not so that they become a designer, but so that they can talk to a designer. And notice also that the trainer credentials are very different across all these different places. Nothing has been standardized yet. So if anyone who listens to this talk wants to learn about design, do what works for you. There's no right way to do it. Try to figure out who are your local experts in design and just talk to them. And then finally, I just want to, close out the talk with just some personal reflection. So these aren't truths that we found from our survey of other educators. These are just, personally what I think I got out of this year. Now that I've been back in medical school for a few weeks, I've been rotating in the ICU. What was the point of all of this design stuff? So the first thing, and this has been apparent throughout the entire talk, getting to real world impact is not a clean sequential process. So the National Institutes of Health is this massive government funded program where Congress is able to pour money into investigating basic science. And in World War II, Vannevar Bush had a wonderful speech talking about the importance of basic science inquiry. It's not necessarily focused on real world impact. It's just focused on increasing our understanding of the world. At the turn of the 20th century, Congress basically asked NIH, okay, we've been funding you guys for 60 years, like what's been going on? And so the field of translational science was born. And so the idea was that, you'll have this phase of basic science discovery, you'll have this phase of validation. So someone has identified a receptor that may be relevant to a clinical condition. And then finally, you have this final process for implementation. So you have your intervention. How do you implement it so that people are using the intervention over and over again? It's not that easy when it comes to healthcare delivery design. You have to do all of these things in tandem at the same time. So when we're talking about, in science, a lot of our paradigms are based on how we use small molecules to treat disease. And if you're using small molecules to treat disease, this is a fantastic paradigm because you have to be very careful at every single step. You have to make sure you know what you're doing so you don't accidentally give someone a poison. But when you're doing healthcare delivery reform, it's a little bit more messy. You have to do your user research, co-design with your stakeholders, prototype, make sure that your solution, like for example, our hypertension action plan, fits the local needs, and you're having implementation and monitoring, and you also have project managers to keep you on track so that you're every week that you're making some progress on this. And this is something that you can't do it in a sequential process. You have to be thinking about these things all the time. Second, design lets you attack very, very messy problems. So this is a figure that has been making the rounds in IHDD for the last year because people have asked me what I think about implementation science. And implementation science is very, very powerful. If you have an evidence-based solution, so let's say, for example, I was in the ICU last week. We had a patient with acute respiratory distress syndrome, and we wanted to basically ask the question, should we prone this patient? So one of the things that you can do for a patient who is having a lot of trouble breathing, who has an acute lung insult, is you can actually flip them on their belly instead of having them lay on their back in the hospital bed. What happens is, because there's more lung tissue in the back of your body than the front of your body, you get better aeration. And so when we're sitting in rounds outside the patient rooms and we're talking about should we prone this patient or not, we refer to something called the PROSEVA trial, where they did a really wonderful randomized controlled trial where they had an arm of patients who didn't get proned, an arm of patients who did get proned. We could ask the question, does the evidence-based solution exist? So we knew that proning can have a positive impact in some patients with a relative risk reduction of, I think, 50%. Patients who got proned with the appropriate indications had a mortality of 16% versus 32%. Was it applicable? In this case, it wasn't applicable to our patient because he had some other comorbidities that wouldn't have included him in the PROSEVA trial. And so we weren't able to conclusively say that there would be evidence of benefit. So we didn't end up proning him. The reason why I tell that story is if you decide to flip the script from inside the four walls of the clinic and you go to something that's much more broad, like, hey, we have a bunch of hypertensives in the south side of Chicago. What do we do? Or, hey, we have this, artificial intelligence screening. What do we do? There's no externally validated copy cutter solution that you can use. So if you don't have an evidence-based solution, if your evidence-based solution isn't applicable, if you've tried it yet, and for some reason, you've put the machine in the family medicine clinic, but people aren't making it to their ophthalmology visits, that's where a human-centered design is very, very powerful. I do want to have an important caveat. I'm not saying this to say that design and science, one is better than the other. There are two very, very, very different ways of thinking. In science, you have a very, very high standard of evidence. To prove causality, you have to have a control arm. You have to have some time-adjusted measures. You have to be able to do all of these different things to show the truth that your intervention works. In design, because you're looking at local contexts and you're willing to prototype and understand what might be done in this specific instance, the level of evidence may not be as high, but it can be very, very difficult to implement things. And it can be very, very difficult to troubleshoot things. And also, you shouldn't be using human-centered design when you're trying to figure out if you should prone a patient with acute respiratory distress syndrome. Just like look up the paper and see what the paper does. So there's this balance between figuring out what interventions are amenable for design and what interventions are amenable from science. The point of this talk is not that we should have some marriage between design and science and do them at the same time. The point is that they're both powerful and they should both stay in their own lane. And so when you're having, for example, a research trial where you're using both design and science, identify proactively what are the parts that you want to use design for, what are the parts that you want to use science for. And then finally, this was a 2x2 that Hugh showed me on my very first day at IHDD. And basically, there's this line where on the left side, you have people with no knowledge. On the right side, you have people with a lot of expertise. At the bottom, you have something that's very inefficient. And at the top, you have something that's very efficient. So on the bottom left, you have explorers. So this is the world of creativity. So we don't know anything about this area. These are the people who are making discoveries. These are the people who are coming up with new ideas. These are the people who are building the next iNooks, who are building the next trials, everything like that. On the top right, and I did this for explore and exploit. I'm not saying exploit as a negative connotation. I'm just saying that in the top right, when you have an efficient process and you know exactly what you're doing, this is the world of business. You're able to actually have some sort of a viable business model. The problem is that it's very hard to get these two quadrants to talk to each other. If you have some brand new idea, it's going to take some cost to actually implement it in your day-to-day. And so it's hard to get these two areas to talk to one another. I think the beauty of dual training in design and medicine is that you can start to play this role mediating between the two. I'm not a designer. I would like to be able to mediate with designers and ask them, reasonable questions instead of asking the graphic designer to do a service design project for me or a service designer to do a graphic design project. So that's really where I wanted to end it off. Just personally, I think this was a fantastic year. I just want to be able to, this is a really long list, but I want to be able to go through everyone. My mentors, Dr. Jerry Krishnan and Hugh Musick, all of the rest of the designers at IHDD, at Onda Collective, Hannah Pick and Faye Gao really led all of the hypertension work that we talked about. The OPHS staff, so Eileen Baker, Julie DeLisa, Cindy Lehman, Tracy Weems. Julie especially was very patient with me when I was trying to get my IRB exemption, and I found a different way to mess it up every single week. The entire Determine team, so Determine was the survey that we did of all of the people who are doing design at other places. The Department of Ophthalmology, which is where I did my first ever design project, and other advisors who I've just been able to talk to about integrating these two fields. And then finally, my parents, who gave me the green light to graduate in 5 years instead of 4, and actually encouraged me to, do something that I was interested in. And with that, I'd love to take some time for questions.